Here we go. Calcium homeostasis. This is split into two parts. We have got non-hormonal, and of course we've got hormonal. So the first thing that we need to deal with is the really easy bit, and that is the non-hormonal part. Now, if you remember from the lecture slides, again, we are drawing a comedy Tom and Jerry bone. In the bone, we have got hydroxyapatite crystals. So, the non-hormonal part of calcium homeostasis refers really to a very, very, very quick response for a drop in serum calcium. So, you know, in the bone, everything is connected. So we get a drop in serum calcium. The hydroxyapatite crystals contain calcium, and they also contain phosphate. So this causes the bone to release calcium and phosphate into the extracellular fluid, where it will eventually work its way into the surrounding vasculature. So it'll go in there, like that, and it will be carried away, which will then, rather than having a fall in serum calcium, have an increase in serum calcium, which will make the serum calcium somewhere back to within its set point of 2 to 2.5 millimoles per litre. So that is the quick response. Okay? And then, of course, this means that our comedy Tom and Jerry bone is now happy again. All right? So that is the non-hormonal, very quick response. So, quick response. That is basically what's going on for most of the time. Okay, the hormonal response to all of this occurs where the non-hormonal response cannot maintain that set point, and your serum calcium is dropping lower than 2, so lower than 2 for significant millimoles per litre. I'm not going to be able to criticize you lot for not using units if I don't use them myself. Lower than 2 millimoles per litre for an extended period of time. Are you happy with that? Says I, looking at my computer screen, expecting you all to be nodding or shaking your heads. You can't nod or shake your heads. Well, you might be. I don't know. I can't see you. So, next thing we've got to do is tidy this whole page up, which I'm going to do now, and then cut back in and deal with the hormonal part of it. So the hormonal side of things, now I've tidied the screen up, is slow. We have got to consider a couple of things. I say a couple, 3. 3 main hormones that you need to consider. I'll tell you what, let's get rid of this. I'll do this over here. We've got parathyroid hormone, which is going to be something that we're going to talk about an awful lot. We've got calcitonin, and we've got 1,2,5 dihydroxy vitamin D. Now this can either be DHD or you will see it as OHD. Both are perfectly acceptable. I may use them interchangeably. So if we just, by way of an overview, quickly go through what all these do. So the parathyroid hormone, as I'm sure you know, comes from the parathyroid. So where's that? In your neck. And it's at the back of the thyroid gland. So you've basically got a situation where, in response to a decrease in serum calcium, we increase the production of parathyroid hormone. That has got some biological effects that will then bring about an increase in serum calcium. Calcitonin is basically a flipped side of it. So calcitonin will be released in response to an increase in serum calcium, which usually comes from a high dietary intake of serum calcium, of calcium from the diet. So an increase in serum calcium means that calcitonin, where's this from? We'll just write in your diet, means that calcitonin, sounds like something from bloody Krypton or something. Calcitonin will bring about biological effects to decrease serum calcium. And that's pretty much the last I'm going to talk about calcitonin, because we're not doing an endocrinology lecture here, we're doing an MSK talk. And then finally, we've got 1,2,5-dihydroxy vitamin D. Where does this come from, I hear you ask? Right, well, you are all told at some point that you get your vitamin D from the sun. It's not necessarily completely true. However, it is kind of true in a kind of a wives' tale kind of way. Basically, in the surface of your skin, you have got receptors to sunlight, which are called 7-dehydrocholesterol. Okay, that will, when in contact with sunlight, cause a chain reaction of stuff which makes vitamin D3. In the liver, vitamin D3 will undergo hydroxylation to 2,5 hydroxy vitamin D, and then with some interaction with the rest of the system, that will undergo further hydroxylation to 1,2,5-dihydroxy vitamin D, which is actually useful in this whole process. Time to have another little cleanup of the screen. However, I would recommend that you just very quickly make a note of all of that stuff so that you've got it in front of you and you understand it and you know the steps, so that when we talk about the rest of it, you're not having to refer back to stuff. Right, so time to have a look at first of all what parathyroid hormone does. So let's start up here. So parathyroid hormone. If we've got a low serum calcium, then parathyroid hormone will be released by the parathyroid glands, and it will act on three things. First thing is it will act on the kidneys. And what it's going to do in the kidney is as follows. So if we now zoom in on a nephron, proximal convoluted tube, loop of Henle, up into the distal convoluted tubule and into the collecting duct. It's going to do a couple of things. It is going to use, parathyroid hormone is going to stimulate in the proximal convoluted tubule 1-alpha hydroxylase, and that 1-alpha hydroxylase is going to convert 2,5-dihydroxyvitamin D to 1,2,5-dihydroxyvitamin D, which we will deal with later. Secondly, it is going to cause an increase in calcium reabsorption in the distal convoluted tubule, and it is going to cause the increase in secretion of phosphate. So it is going to stop the proximal convoluted tubule from reabsorbing phosphate. The overall effect of this is that in response to parathyroid hormone, we are, via the kidneys, we are going to get a decrease in phosphate, and we are going to get an increase in calcium. Okay, right, now, bone. In the bone, parathyroid hormone will increase the activity of osteoclasts. It will cause an increase in the maturation rate of osteoclasts, and it will cause a decrease in the activity of osteoblasts and collagen in the matrix of bone. The net effect of that is that we will get a decrease in phosphate, and we will get an increase in calcium. Right, that's good. And then we've got something else to consider, which is the gastrointestinal tract. In the gastrointestinal tract, parathyroid hormone will cause an increase in the absorption, not reabsorption, but the absorption of calcium, and it will cause an increase in phosphate absorption. The net effect of all of these, because we've got, don't forget, we've got one thing that is increase in phosphate absorption and two things that is decreasing it, is that in response to a decrease in serum calcium, parathyroid hormone will cause a net decrease in phosphate and increase in calcium in our serum and our plasma. Okay. Let's have a little tidy up. Actually, let's not have a little tidy up, because I've got enough room on the side of the screen just on the right here that I can fit this in. So let's just do this a second. In response to an increase, that increase that we've just generated here of serum calcium, I know I said I was going to leave calcitonin, but for completion's sake I should probably just do this. We're going to also affect, can't bother to draw them again, kidneys, bone, GIT. The kidneys, calcitonin will try to decrease calcium reabsorption from the distal convoluted tubule. It will decrease, and it will bring about, not decrease, my apologies, and it will try and bring about an increase in phosphate reabsorption. In other words, we're trying to undo everything that's happening on the left-hand side of the screen. In bone, what we're going to get is a decrease in osteoclast activity. And then in the gastrointestinal tract, I think by now you can probably guess what happens. You're wrong. What happens is nothing, because we've got a different enzyme called gastrin that deals with that. Now it's time to have a tidy up. Okay, tidy up has happened. So now we're looking at 1,2,5-DHD or OHD. And what it is going to do with the kidney, the bone, and the gastrointestinal tract. So, in the kidney, what it will do is it will also cause the distal convoluted tubule to increase calcium resorption. But now that we're generating 1,2,5-DHD, don't forget parathyroid hormone did this in the first step. It caused the conversion of 2,5-DHD to 1,2,5-DHD, so 2,5 coming from the liver, and then the kidneys causing the extra hydroxylation to turn it into 1,2,5. In that process, we started to decrease our PO4, our phosphate, because the parathyroid hormone caused the kidney to increase phosphate excretion. 1,2,5-DHD, when we're starting to generate it, actually shuts down that process, so it works to begin PO4 reabsorption, and that happens in the proximal convoluted tubule. So let me get that right. Just make sure that we're all figuring this out. So we got a nephron, the proximal convoluted tubule, the loop of Henle, distal convoluted tubule, collecting duct, and what we were having before was the parathyroid hormone causing the 1,2,5-DHD production, but the parathyroid hormone was causing an increase in phosphate removal, and the 1,2,5-DHD will then act on the proximal convoluted tubule to start increasing phosphate, increasing calcium resorption, and then that process gets shut down. Okay, what does it do to the bones? Well, it's got to take a bit of a detour here. So 1,2,5-DHD will go via the parathyroid hormone, and then increasing parathyroid hormone, so there's a little bit of a feedback loop, will cause an increase in calcium, but a decrease in phosphate via the mechanisms we just talked about. In the gastrointestinal tract, we get an increase in calcium and an increase in phosphate absorption. So there we go. That's parathyroid hormone, calcitonin, and 1,2,5-dihydroxyvitamin D all sorted. You should now be in a position where you can go back and look at the slides on slides 28, 29, and 30 for the diagrams, 31, 32, and so on. Where do we stop with these? 31, 32. Yeah, 32. And hopefully they make a lot more sense to you now.